Patients who have ulcerative colitis who are making a decision about surgery are making a really important decision. The two options are equally effective, but they're very different in terms of the risks, quality of life afterwards, and what daily life is like. So my first research interest was to learn about how we could support patients in being involved in the decision about surgery. It's thought that increased patient involvement is really going to improve patient satisfaction, quality of care, and outcomes. And what I found was that really little is known about how patients make a decision about surgery. So this study was to actually get that basic background information that we needed to know what patients are doing, how do they even want to be involved in the decision about surgery, all of those things that we really needed to know. And what we found was that overwhelmingly patients do want to be involved in the decision about surgery. 100% of our patients said that they wanted that. It was a small study with only 25 patients, but all of those did indicate that that was the case. We also found that patients tend to be very motivated to learn about surgery. So on average, our patients were spending 6 hours learning about their options before they even saw the surgeon to discuss the options. In spite of that, they still didn't know all of the information we felt to be the most important. But again, they still hadn't seen the doctor to actually hash out all those details. And finally, we found that they were really interested in discussing the decision with other people in their life, namely family and friends, but that those discussions were really important for their decision-making process as well. The term that we use is shared decision making, and what that describes is the process where a physician and a patient sit down together and have an open discussion. You know, the physician is bringing their expertise, so they know a lot about the disease process and all the options, and the patient knows what's important to them as an individual. So the final decision that's made reflects both the evidence base that the physician knows and the patient's preferences and values. So it's shared in that sense. This is all not only before surgery, but before meeting with the surgeon for the first time. The reason we chose that time point is, generally speaking, the decision about surgery is made during the very first contact with the surgeon. So we were capturing the patients before they actually made the decision so that we could really get a sense of what was going on during that decision-making process. So essentially, ulcerative colitis is a disease of the large intestine, and when you remove the large intestine, you're left with the small intestine, and you have to figure out how to get the stool out of the patient's body, essentially. The first option is that you take the piece of small intestine and you bring it up to the patient's abdominal wall so that the stool is actually emptied into a bag that's worn externally on their skin. That's called the ileostomy. The second option reconnects the small intestine so that bowel movements continue to pass as they did before surgery. That's called ileal pouch anal anastomosis, or a J pouch. They're actually quite different risks to each one. The most important thing is that both operations will cure the ulcerative colitis. The ileostomy option tends to have patients can have some problems with dehydration after that surgery, and then there are some common risks to both, but that would be the one that's more specific to the ileostomy. And then the J-pouch option, people can have problems with the hookup. So, and then there's chronic problems with the actual functioning of the pouch, because now you're asking the small intestine to behave the way the large intestine did. And although it can try, it never does a perfect job. Focusing less on the surgical complications of each is probably those complications are less important for this decision, more than the actual daily life afterwards. So the things that we really try to communicate to patients is that although the J-pouch options allow them to pass bowel movements as they did before surgery, their bowel movements never goes back to normal. So best case scenario, they're going 6 to 10 times a day. And so that's kind of the quality of life piece there. With the ileostomy, of course, it's, some psychological adjustment and, dealing with the actual bag portion. So it's very different in terms of the quality of life after. I suppose the surgical complications during the procedure are also something to think about, but I find that patients are more interested in the daily life afterwards. The patients are doing research using a variety of sources, and we found that the two most common sources that patients were using were actual physician-provided information and internet sources, although we didn't actually ask them which specific internet sources they were using. So our results help by showing that, number one, patients want to be involved in decision making about their healthcare. And we identified some specific ways in which we can intervene to help them participate in decision making. We found that patients don't have all the information they need, so designing tools that actually give them the information that they need, which are the information about the risks and that sort of thing, but also the information that they want. So making sure that we're actually addressing those kind of daily life, quality of life issues afterwards. And finally, helping them understand how their preferences and values apply to the decision and can help them actually make a decision that makes sense for them. We wanted to design these tools for the specific patient population in a paper-based format so that it was easy for them to take it and use in the discussion with their family and friends, as well as a place for them to write down questions that they have so that they can bring it in so that it's very useful during the discussion with the surgeon. And actually the outright harm that's done seems to be relatively low, although I think the thing that you really want to protect is the patient-physician relationship. And I think that when patients are bringing things in and the doctor can explain things to them, it can actually bolster the relationship. Up to 30% of patients with ulcerative colitis end up needing surgery at this time. It would be ideal if none of them needed surgery, but one of the problems that we'll probably never get around is that there's two indications. One is the disease is not responding to medicines. And the second is that they develop dysplasia or precancer or cancer. So I don't know that we'll ever be able to fix that problem, so I think surgery will always be one of the mainstays of treatment for ulcerative colitis. But as medical therapies improve, we'll hopefully be able to move away from using surgery as a treatment, and I think that will ultimately be better for patients as well. We have two studies that we're doing now to try to address the findings that we found in this one. One is we've designed and are doing a pilot study of a decision aid for patients who need surgery. This is a specific patient education tool that has the information about the surgeries, what life is like afterwards, and then has what we call values clarification exercises, which ask the patient a question about what's important to them and helps them see how their answer could actually be used to help them make a decision between the two options. And so we are doing that study now. And the second one is that we're doing interviews with patients who have ulcerative colitis, who have undergone surgery. We're hoping that with the benefit of hindsight and kind of knowing what they know now, we can find out not only what's important during the decision-making process, but also what information people should have when they're making the decision.